Okay. So, hello and warm welcome. Good evening, everyone. I am Dr. Rakesh Sonavne, medical advisor from Sanofi. Welcomes you to this exclusive panel discussion on management of osteoarthritis in India for surgical and non-surgical approaches. So this is the period of panel discussion, and you are aware there are so many discussions happening around the world, also on these US elections. So I thought it will be a breather and an enriching session on discussing osteoarthritis in current pandemic era. And for this, we have the exclusive and eminent panel of experts with us. I would like to welcome each and everyone for joining this webinar. And for this webinar, we have our moderator, Dr. Sachin Tapasvi sir. And to join with him, we have a eminent panel of experts of orthopedicians from India, Dr. Vijay Kakatkar sir, Dr. Brajesh Dadriya sir, Dr. Guruva Reddy sir, and Dr. Anand Kishore Pal sir. So I would just take a few moments to introduce our experts, and then we will go ahead with our procedures. Dr. Sachin Tapasvi sir, who is our moderator for the session today, he is a consultant orthopedic surgeon at Orthopaedic Specialty Clinic. He is head of department there. Dr. Sachin Tapasvi sir has an area of specialization in arthroscopy, sports medicine, and orthoplasty. He has specialization in knee surgeries as well. Sir is chairman and organizer of A to Z knee cadaveric courses at SRMC Chennai. He was co-chairman for the first lower limb deformity course at Pune. He is course director and chairman for the 3 Pune knee rehab courses and 9th Pune knee courses. Cadaver courses, various workshops, demonstrations, attended as a faculty and a course instructor. Sir is also a well-known faculty, guest lecturer at various international and national conferences. Sir is also editor for various journals, and sir has so many publications to his name in the international and national journals. Welcome, sir. It's an honor and privilege to have you today for our meeting as the moderator. To welcome our next experts, I would like to welcome Dr. Brajesh Dadriya sir. Dr. Brajesh Dadriya sir is exclusively practicing orthoscopy, sports injury, and joint reconstruction, especially knee and shoulder. After completing masters in orthopedics, he has done fellowships in arthroscopy, sports medicine, and joint replacement from prestigious centers of excellence in Germany, Austria, and France. Dr. Dadriya's practice has a strong focus and keen interest on arthroscopy and reconstructive surgeries. Dr. Dadriya has been credited for the development of shoulder arthroscopy and sports medicine in Mahakoshal region. Welcome, sir. Thank you so much for joining as an expert for this panel discussion. Also, we have Dr. Guruva Reddy, sir. He is the founder and managing director of Sunshine Hospitals. He is active faculty member and examiner of the Royal College of Surgeons, Edinburgh, UK. International committee member, American Association of Hip and Knee Surgeons. He is editorial board at Orthoplasty today. He is founder member of Indian Society of Hip and Knee Surgeons. He is president-elect for ISHKS 2021. He is program director for orthoplasty fellowship programs, offering 14 fellowships of 1 year duration. Thank you so much, sir. Welcome, sir. To introduce our next expert, Dr. Vijay Kakatkar, sir. Dr. Vijay Kakatkar, sir, is a senior orthopedic consultant from Nashik. He is the head of department at Ramakrishna Medical Research Center. He is the founder member of Maharashtra Orthopaedic Association and past president of the association. And he is also past president of Nashik Orthopaedic Society. He has arranged CMEs and workshops. He is a beloved clinician, orator, and has delivered lectures in various international and national conferences. He has various publications to his name, like JBHS British Journal. Welcome, sir. Thank you for thank you for joining this meeting as an expert. And we have Professor Pal, sir. He is the youngest youngest professor at 42 years of age. He has more than 35 international and national publications in index journals. He is author of book on Atlas of Orthopedic Surgery. He has been selected as one of the inspiring orthopedicians of India for the year 2019 by Economic Times, and now acting as a professor and head of Department of Orthopedic and Traumatology at IPGMER, SSKM Medical College, Kolkata, West Bengal. Welcome, sir. Thank you so much for joining. I think we have completed our round of introduction, and I would like to hand it over the session to Dr. Sachin Tapasvi, sir, who is our moderator. Welcome, sir, and over to you, sir.
Thank you so much, Dr. Rakesh, for your kind introduction and for setting up this lovely program together. Indeed, I think it's a great privilege here to be sharing this dais with one of my mentors, Dr. Kakatkar, very close friends, Dr. Gurva, Professor Pal, and a very upcoming and well-established and the future of India, which is Dr. Brajesh Dadriya. The topic that has been chosen today essentially is a dialogue, a discussion between all of us here, and it essentially aims to look at as to how we should take our practices ahead in this so-called restarted life or restarted period for all of us, which I think is quite important as we move ahead. We've gone through a lot of phases, ups and downs, ever since we had the lockdown coming in, which started way back for us in the second or the third week of March. And now we are in the first week of November, almost having spent more than 6 to 7 months trying to come in grips with different modalities of practicing orthopedics and looking at different techniques. We've evolved, we've learned a lot, and I think there's still quite a while we must go ahead before we can really say that we were what we were, probably practicing in the same manner as what we did in February of 2020. So I'm going to be having an informal discussion with seniors and my friends here on this particular platform. And essentially, since this is going to be an interactive session, I am going to welcome all comments, all questions that come in from all our respected attendees, which we see are more than 70 right now, as I can see on the Zoom platform. I'm aware that there are far more who are watching us and who wish to interact with us on the Facebook Live as well as the YouTube platforms. So please keep typing your questions in the question and answer box, which is there at the bottom of your screen. I'm very sure that most of you are very well aware as to how to use the various features of this Zoom webinar. And of course, we do have our webmasters as well, who will send in any questions if at all they come through. So I think I would like to start off by opening this particular question. And I'm going to have a quick comment from all our four speakers here. Let's start with you, Gurva. How far, so as to say normal, in terms of percentage, are you in terms of what you were in February 2020? I think that is one question that keeps getting asked. How much percentage normal are you now? So let's have quick comments from Gurva, Dr. Kakatkar, Dr. Pal, and Dr. Brajesh, because all of you represent 4 different corners and 4 completely different practice scenarios.
Yeah, so good evening, Sachin. It's a pleasure to see you all in this platform. See, you know that I got 2 hospitals in Hyderabad, and we have a big volume there. In the pre-COVID days, in February, for example, my outpatient load was 120 to 140 per day, and 15 to 20 joint replacements. That was my load. Now, I'm not seeing outpatients still physically. I'm seeing them through MFine, one of the apps for the online. So every day I'm spending around 3 hours, 10 minutes each consultation. So I'm seeing at least around 30 patients a day. That is online consultations. And coming to the surgeries, we are now doing almost 8 to 10 joint replacements at the moment. So 50% volume of the theater has come, and outpatient volume is still not yet come because we are not open. And the trauma is going on, arthroscopies are going on, and but all of them are, let us say, pegged at around 50 to 70%, not the full blown.
What about you, Kakatkar sir? I mean, what percentage of normalcy have you achieved in your outpatients as well as your surgical practice?
Thank you, Sachin. And I think as far as our work is concerned, we have a mixed kind of work. We have cold orthopedic work in the OPD, like spine work, the degenerative joint diseases, plus trauma, So the trauma has started picking up after the lockdown has become little lax. And trauma, I would say we are almost about 60% back to our work as far as the trauma is concerned. The cold OPD is almost 70% back to the original. But the other cold work like operative cold work like scopies and plasties, I think is still just about 10% or 20% of what we were doing before. So that's the scenario that we are having. Because initially we had kept a lot of restriction on patients coming from outstation to our place because of the risk of transmission of COVID. And to be very frank, number of patients are still quite scared to come to the hospital premises because they feel that every hospital, they have a chance of getting in contact with the COVID patients. But ours being actual only specialty hospital of orthopedics, we are really not having that much of problem of COVID. So we are gradually resuming our work back to almost 70%.
Dr. Pal, your comments, please, because you are also associated with the medical college, which makes things in a completely different perspective, where you're looking at different kind of loads, you're looking at different patient population completely, and there's also this responsibility of looking at teaching, etc. So what percentage of normal are you now, so as to say? Could you kindly unmute yourself, sir?
Yeah, good evening, everybody. So yes, you rightly mentioned that I am working in a very different situation because I am in a government hospital. So actually before COVID in OPD, this is the only referral hospital in the eastern part of the India. So we had to cater at almost 1,000 patients in OPD per day before COVID. But for the last April, May, June, it was under lockdown. So it was absolutely nil. Now, after that, it is open. But during that lockdown period, that we had only performed the emergency cases, only the trauma cases. So still, our total in the four months, that is April, May, June, July, up to the middle of the August, when the lockdown period is completely released, that we had to perform almost 450 cases. 150 trauma cases from different parts of the country who would suffered from different by ambulance or they're very critical patients. And our new trauma center scattering 141 beds just opened 6 months before lockdown. So it was completely busy now. And now it is almost 60 to 70%. It is completely filled up. And now it is going to become almost full blown. Now in the OPD, that's in comparison to the pre-COVID era, that is almost 1,000 per day. Now it is coming to 600 to 700 per day. And we are performing, that is initial screening of the OPD cases by our juniors. Those who are little bit critical cases, those are referred to our senior persons. Those senior persons, basically, they are actually working under the between the patient and the consultant with a screen. The screen is there, and through the screen, actually, they are confronting, they are taking their histories, and only those cases we require some touching of the patient, they are sending to some specific room where the specific precautions are maintained to touch the patient. That is the way we are now maintaining almost 50% workload, 50 to 60% workload in comparison with the pre-COVID area. Now the teaching, yes, teaching is hampering significantly. Now before COVID area, we have almost 4-5 days a week for teaching purpose, and there are at least 5 or 4 clinical cases, there's real classes, and there are 1 or 2 the seminar classes. But now we are just refers now. There are the 60, that is 2 to 3 the virtual classes we are catering, and only 2 to 3 real classes per week. So per week we have just restricted that that is one single long case or single short case for the patients, for the students, and the students are actually they're invited, those who are seated very scatteredly. So there is 2 or 3 clinical virtual classes and 2 or 3 the online classes. So in this way we are started we are running our teaching. Okay.
Yeah, thank you for that. And Dr. Brajesh, sitting in the center of India at Jabalpur, what's been your take? I mean, what percentage of normalcy have you reached in your private practice now?
Sir, good evening. Almost 70% for my knee work. It means all the scopies we have started for the knee. For shoulder, almost 50%. We are doing the curves and all those things, bank cards and everything. We are delaying all those cases which we can delay safely. We are delaying for the shoulder because those are mostly the GA cases. Except my arthroplasty and high level osteotomy, we are doing everything for the knee, means in scopy part. So grossly, I'll say it is almost 70% of work what we have resumed. Same here, the OPDs, we have returned to almost 65 to 70% of our workload in OPDs, not for myself alone, for almost everywhere in the, means in my city at least. So we are hopefully, if conditions will be favorable, then very soon we'll achieve almost the normal work schedule.
Right. So perfect. So I think that's a good way, a good understanding as to how different workloads have changed and how they have shifted. The main topic of discussion today is how do we manage osteoarthritis, which forms a huge bulk of our practice, both as inpatient and as the outpatient as well. Because practically almost 3 to 4 out of 10 people who do come into our OPD, whether it is Guruva's specialty outpatients, or whether it is a teaching college, or whether it's a huge practice like Dr. Kakatkar's or Dr. Brajesh, will involve some or other element of knee osteoarthritis that needs to be taken care of, because we will accept that knee osteoarthritis is still probably one of the most important reasons why we do get outpatient visits and surgical treatment points, besides back pain as well. So with this now, Guruva, with your specialty practice where you're looking predominantly into knee arthritis, I have 2 very pertinent questions for you. Is that one, how satisfied are you examining and evaluating your patient on a digital platform where you can't touch, move, feel, see if the knee is lax? That's one. And the second thing is that how satisfied are patients with your evaluation and assessment without you having being able to actually listen? You can judge the pulse of the patient and then change the level of your conversation with them.
Yeah, it's a very pertinent question, Sachin. But fortunately, unlike you arthroscopy guys, arthroplastic guys, we just need to see the patient walking and patient's deformity on standing. And technically, you don't need to do your all tests, whether your posterior corner is stable, whether your anterior drawer is positive or not. These are all very, very technically demanding and physical examination systems. Arthritis usually, by the time they come to me, it's a tertiary referral. And I spend 10 minutes. I first ask the patient to show the knee joints, extension and flexion, and then take them through a walking pattern, and then ask them to sit back along with whoever is the next one, or the husband, daughter, or daughter-in-law. That is a very important point. I want both of them in the frame of the camera, the phone camera. And then I start explaining for at least 5 to 6 minutes. I got some pictures with me, like stages of arthritis and all that. I show them, and then I explain to them. And in between, I try to put some social relevant questions, like where do they stay and all this stuff. So the overall satisfaction for me is appropriate, in the sense I'm not missing that much as far as the diagnosis is concerned. I'm not missing that much as far as the convincing the patient is concerned. And from the patient's perspective also, it is much more than what I expected. Initially, I was very cynical and skeptical. But even the rural people, Sachin, the rural people, with that, thanks to the internet and thanks to the smartphones, every day I see at least 5 to 6 ladies without support of anybody. Just they open the smartphone, open the platform, and then talk to us, which is very, very heartening, the digital revolution. So that is another perspective. Overall now, what's happening is the patients also realize that Dr. Guruvara Reddy will not see us physically, but this arthritis has to have an answer. He is operating, so let me go with the digital and then get into the operating room. That is the perspective they have got into.
That's really enlightening, and I think that's very good that you've been managed to do that. One question while we're still on it, with this sudden change in the load, you're seeing about 120 patients physically every day, and now you're 30. What do you feel? I mean, the other 90 that you were seeing, where have they gone? I mean, were they the ones that were deserving surgical intervention, or they were probably the ones you would have said you don't require a surgical intervention?
Yeah, that's a very good question. Out of 120, to my extreme dissatisfaction, around 20-25 are back pains. I refuse to see them, but they say, no, we want you to see. I see them and send them to spine surgeon or act like a quack, literally, for the 20 patients. So those 20 patients, I'm not seeing them now. Digitally, when they come, I told my digital platform, I'll not entertain anything other than the knee pain. So those 20 to 30 have gone, and some of them are follow-ups. So those people are also waiting. So these 30 out of 30, almost 20 are surgical candidates.
Lovely. So I think that makes it quite, completely sort of satisfying, and it does that. Yes, Dr. Pal, you had a point to make?
Yes, regarding this, I have a very good, I can give a good example. So one patient has come just once the lockdown has become over. He has a relative of his renowned physician. He actually referred me that this patient has to be operated by totally replacement, as he is unable to walk just after lockdown is over. He's noticed that he's unable to walk because of some problem of that. So once I have examined that the X-ray is severe, very, very poor. It is a grade 3 or 4 osteoarthritis of both the knee joints. But the problem is actually he has some low back, as Dr. Guruvara is rightly mentioned. He has a low back pain for a long time. And now he is complaining of neurogenic claudication, and that is why speed is reduced. And as there is some knee pain in the knee, but that is not his complaint. Main complaint is reduction of his walking speed, and that is the main problem. So actually, I give some exercises and spinal flexion exercise and medication. Now he is satisfied. He is not asking for the joint replacement now. So these are why. That is how, as you have told us, what are the 120, 90 cases where is gone. So that is the one of that. Is a good story.
Yeah, okay, that's a great point, Dr. Pal. Dr. Brajesh, I think, I think the one question that I really have for you is that when you're dealing with your patients, so what do you think what is your guidance for elective surgery? Since you said that you're electively, your patients who do recover a GA, you are avoiding to do them. Why do you say so? Why are you trying to not do those patients who probably do have a torn cuff or who do have osteoarthritic knee in which you need to do, say, a partial or a total knee arthroplasty? Why are you saying no to them now?
Sir, as we all know, there was a lot of risk associated with the cases involving the general anesthesia. There was a lot of publications or in the various webinars, it was said, those cases who require general anesthesia or a lot of bone cuts and everything, it was associated with a lot of infection to the doctors. So I was just scrutinizing and selecting the cases who were
Well, I think I have almost the same pattern of work that I was following before the COVID. I am quite selective about advising surgery. So as far as possible, I would go for a non-operative treatment, which includes all physiotherapy modalities, the pharmacotherapy, and the offloading braces. And once enough trial of all these non-surgical modalities are done, then I would go for a surgery. That was my policy even before, and even today I follow the same pattern of my work for the osteoarthritis.
So what specific, in your non-surgical treatment of osteoarthritis, have there been any changes that you've done of late in this COVID era? Have you started, using different medication, different pharmacologic agents, something like bioactive collagen or different type of, other collagen preparations, denatured collagen? Have you used more of them in your patients? Have you encouraged your patients to take more of these pharmacological agents? Have you started advising more injections? Either proactively, or have patients come back to you and said that, let me just wait for 3 months. Till that time, can you help me with something else? So what has been the case? Has it been the first or the latter? And what have you used? Just for us to sort of be aware of.
To be very frank, the patients also are a little reluctant to get operated during this COVID period. And sometimes even if you advise surgery, they say that let this COVID get over, then we will come for surgery. And during this time, I have been using this collagen type 2 preparations quite regularly. And in mild to moderate cases, I think they are giving good results. Of late, in the last about a year or so, I have been using PRP injections also in mild to moderate cases with in some of them very excellent results. Even with single injection, some of them are almost asymptomatic for almost 1 year. So I have been using those, plus preparations like Cinevis also we are using. I am not very fond of using intraarticular steroids right from the beginning of my practice, and that I still discourage using for my patients. But other pharmacological like anti-inflammatories, oxaceprol and glucosamine plus some curcumin combinations, these are the medicines which I'm using more often than what I used to use before for the non-operative management of these patients.
Guruva, I think, before we got into this phase of COVID and the new things that we sort of, learned with passage of time, we were doing our knee arthroplasties, whether it be partial, totals, or whether it was a revision in a certain way. From March, when we shut down till now, what are the different changes in the surgical technique or the surgical armamentarium that you have evolved till date?
Technique-wise, there is no difference, Sachin. The same. Yeah. We got the Mako robot. In fact, we were done around 200 cases. Then the COVID struck. So now we have gone back to the robotics. So nothing changed as far as the technique is concerned. And nothing changed as far as our fellowships, our training is concerned. The only thing is every patient is getting a HD CT scan, chest, preoperatively. That has become a mandatory. It's like a screening tool. And so that is being done. And that's all the difference. Otherwise, no difference. In fact, our hospital has we treated in the peak COVID time, 90% of my total 400 beds are occupied by the COVID patients. Right now, as I talk to you, around 30% are COVID and 70% are non-COVID. So the challenges are geographic isolation and that COVID, non-COVID separation, and the reassurance of the two non-COVID patients that you are not going to be mixed with COVID patients. That is the biggest challenge.
So in terms of surgical safety, are you using helmets, body exhaust suits? Are you not using them? Are you using something different just to make sure that there is less aerosol generation using plastic shields? What are you using? Anything different?
As far as my personal choice is concerned, I'm using the same old our masks in the like previous one, because the other masks like N95, I get suffocated feeling. Somehow it never suited with me. And I'm not using the shield also, just normal mask. That is number one. But some surgeons, young surgeons,
Checking them for antibodies. Have you taken swabs for them? And what are you taking to look after your staff? Not only just your doctors or your immediate residents, but also your next line, which are your nurses and your class 3 workers as well.
Yeah. So first of all, as per government policy, they have already told that at least 60%, 50 to 60% staff should be present and 50% should be off. So 50 to 60% staff actually they are requested to stay inside their quarters. So once they are in India, they are in the service, they cannot leave home at least for 7 to 10 days at a stretch. So for 7 to 10 days, they are initially once they come from the home, they are already screened as by clinically, as also if there is any problem, and they sent from that quarter. So they will stay for at least 7 to 10 days at a stretch. That is one. Second, during this operation theater, so if there is any problem, any suppose there is some temperature check, everything is there is any abnormality is detected, they are already sent to the our fever clinic. Fever clinic and experts are there. If there is any problem, any suspicion, they check their swab test. And if the swab test is negative, then only he or she is allowed to enter inside the OT. That is second. Third one, there is dress code. The dress code is absolutely PPE kit. So that is whatever the patients, because some patients we had to operate even without COVID because of some emergency situations. So suppose there is some open injury or like that. So we cannot wait for the COVID test or HRCT. So we had to operate. So all the staffs, all the 4th class staffs, nursing staff, those who are working in our OT, all they are actually use this PPE kit, actual PPE kit, which is required to be worn by at least 15 to 20 minutes is required, and proper donning and doffing, proper room for doffing and donning, everything is maintained. And actually the working hours is reduced from that. Initially it was 8 hours. Now the working hours is reduced to 4 to 6 hours. So depending on the situation, if the work is completed within 4 hours, then he or she is released from the work. So in this way, they are actually they are maintaining their health. And even if there is any problem, at the end of the work, she or she is allowed to attend the fever clinic, and some special clinic is already there, so to check their health status. That is
okay, perfect. So very quickly, Brajesh and Guruva and Dr. Kakarkar sir, are you conducting your OPD in PPE kits, or you're just using like a simple face shield or an N95? Brajesh, we'll start with you.
Sir, a simple face shield and an N95, that's all. And I always use gloves, each time I change the gloves whenever I'm examining the patient. So that's all.
Guruva doesn't wear a face shield when he's doing digital, so that's fine. That's good. Dr. Kakarkar, what about you, sir?
Well, N95 plus face shield, a full-length gown, and gloves. In OPD, all these things are compulsory. Every patient and the relative entering into the OPD has to be with a mask on. Correct. And the entire staff who is working in the OPD has to have a full gown, gloves, mask, and a face shield. That's the standard protocol that we are following.
Do you disinfect and sanitize surfaces,
yes.
Which the outpatients come into contact every time one patient goes up?
What we are doing is that we have kept 2 couches for every surgeon, and they are without any linen. It is only a resin cover for the pillow as well as for the couch. And after one patient goes out from that couch, that particular couch is sprayed with 1% sodium hypochlorite solution. In the meanwhile, you examine the patient on the other couch. And by the time this patient is over, this is dried up, so you take the next patient. And at the end of the day, we have kept an agricultural pump in the hospital for a spraying of sodium hypochlorite. So the entire floor, the entire dado, up to say 4 or 5 feet height where the patients or the relatives are likely to touch. Every evening, the entire area of the OPD is sprayed with 1% sodium hypochlorite. So that we have been following every day. Every patient or the relative entering in the hospital has to have a hand sanitizer on his hands. Without that, he cannot enter. His oxygen saturation and temperature is checked with the infrared thermometers. So that's all that we are following for every person entering into the hospital, indoor or OPD, both.
Guruva, I'm sure you have a lot of special tricks up your sleeve which are not mentioned in any textbooks, and I think I will not leave this opportunity to ask you, what is that one special trick that you have up your sleeves where you're able to convince your patients that it's safe to have a joint replacement or a joint procedure right now?
A question stumped me. I don't know, Sachin. I cannot put a finger on that. But to my delight and surprise, it did not take much time to convince them to come back. Probably the rapport which we built over the years, and the people, because of my secretaries, my patient counselors are in regular touch with them. And so that might have helped, because a lot of people know my secretaries and my patient counselors' phone numbers personally. So they started ringing them after this peak 3 months are over, from the month of September. So they started when the operations are getting started and all that. So we already got the pool of some patients already ready to come. And the only thing is I have to talk to them by video to reconvince them and give that final seal of approval. The atmosphere is clear, come down, we got enough safety precautions, come down. So that's what it is.
Yeah. You don't show some videos to them of your dances?
Yeah, that's part of it probably. Yeah, end of the day, the patient thinks that he owns Guruvarati. And that is the one which I created, something serendipity, something by nature, it has happened. So patient feels comfortable if we say that. That's what helped me.
Lovely. So Dr. Pal, as Dr. Guruva is using an HRCT as a diagnostic screening tool. What is the modality that you choose? You said that when you have a certain emergency where you just can't wait for any test to come back, you do take them, and assume that they're COVID positive. So what is being used in your center, especially for doing any surgical procedure? What's the screening tool that you use?
Yeah, there are two types of patients we are catering. That is at a one emergency. Suppose there is some painful swelling around the elbow because of the pulse left supracondylar like that. Another is the cold cases. Suppose there is neck femur fracture waiting for the arthroplasty. So for the emergency cases, what we are doing, that is there is a serum, that is a rapid test. Rapid test. If it is IgG, there is an old infection. So there is not much of important. So we can go for the usual procedure. But if it is IgM, then we have to use all precautions, including the PPE kit and everything. But we are sending the COVID test at the simultaneously. But we cannot wait for the COVID test, and we do the surgery with all the PPE kit. But for the cold cases, we routinely do the COVID test and we wait for that. And after once it is COVID negative only, then we can do. If there is some suspicion, then we use HRCT, because HRCT is very costly and it is not within reach of every patient. So that is why we are not recommending for every patient for HRCT, but we are doing the COVID test every patient. For the cold case, the elective surgery, if it is positive only, then negative only, then we will go for the surgery.
Rajesh, what is the norm with you?
Sir, all patients, they need to undergo the RT-PCR for the COVID and HRCT test. Without HRCT test and RT-PCR for COVID, we don't allow any patient to go inside the OT. So these
you're doing both of them. What about you, sir?
RT-PCR compulsory for everybody who goes for planned surgery, except maybe some vascular injuries or compound injuries where we have to take them up without waiting for the RT-PCR report. But X-ray chest is done for everybody. We don't send them for HRCT.
Perfect. Again, Guru, I'll come back to you. I'm not in Hyderabad. I'm in, say, a smaller district place. And I was doing maybe 15, 20, 25 knee replacements in a year. I want to restart again. I don't have a huge setup like Sunshine. I don't have a huge setup like Dr. Akatkar's hospital. I'm not in a big medical college with all the backup like Dr. Pal. I'm not in an ultra-modern institute, which Dr. Brajesh does have. So what should be the steps that I should go through when I want to restart my knee arthroplasty? I have the couple of patients coming back that, which I've been putting off using undenatured collagen preparations or using bioactive collagen preparations. But now he's come to the end and he says, now I need something. So what would you advise me if I came to you for advice?
Yeah, again, it's all in establishing the faith in the patient. I always say that two things to my fellows and all that. Number one is doing good. Number two is being seen as doing good. The number two is the one where a lot of us fail. In communicating to the patient the efforts we take in their welfare. This is the time which we have to rededicate ourselves or re-introspect ourselves to that aspect. Because all the doctors do good. There is no doctor who leaves home to kill a patient. But the part two is the important part. And that is where I keep telling the people to learn that aspect. So I would advise this young man in the district or wherever it is to spend 1 hour with the patient to tell the 20 precautions he is taking to see that the patient is comfortable. He has to get them typed, he has to get them nicely brochured, and he has to use the visual techniques, videos, to show him that these are the things which you have done. These are the things which you have taken to your comfort. But that has to be done. So pre-operative counseling, if he doesn't have time, he should use his patient counselor to show that. So once the patient knows all the things the doctor is taking, then he will go ahead with that. Even after the surgery, if he becomes positive also, he won't mind. So that also you should tell the patient, 10% chance you might be positive, but it is just like another cold, you will be all right, we'll take care. And we got enough support services to take care of that. So that sort of conviction and that sort of convincing the patient about the measures which we have taken should do the trick.
Yeah, I think that's a great point that you've made there, Guruva. And on the same point, I'm going to ask you, Dr. Kakatkar, that, or Dr. Pal and Brajesh as well, or even Guruva, you can come back and give me some numbers if you have. Of all the patients who have been non-COVID patients that came in for surgery to either of your setups, how many of them really went back being COVID positive? I think that's a very important aspect because that's the fear that I'll come and I'll become COVID positive and I'll go back. So let's get a number from all four of you. I mean, it could be completely anecdotal. So let's start with Dr. Kakatkar. Have you had any patient in the last couple of months who was RT-PCR negative, came for surgery and unfortunately got infected and went back as a positive patient? Yeah. Or went home and became positive?
In the last, say, about 4.5, 5 months time, out of whatever elderly patients we have operated, 2 of them, because they had multiple medical comorbidities, including ischemic heart, I shifted them to another setup for doing surgeries. And before shifting them, they were COVID negative. After shifting them over there and operating, within 2 days, they were shifted back to our place. And 2 of them in the last 5 months, they turned out to be positive after the surgery. So we had to, really analyze ourselves whether it was going to the other setup where they got the infection. But in our own setup, luckily in the 5 months time, we haven't had any patient who came negative and then went back positive. But
Rajesh, what about you?
Just one patient became positive just almost 20 days back, sir. I had just operated him for the cuff and he was discharged. He was very comfortable. I discharged very next day. And after means he forcibly he called me, doctor, I have got a gift from your hospital. I just asked, what is it? I have become positive and now I am hospitalized. So that was, he was the only patient. But sir, almost in last 3 months, there was almost 11 or 12 patients to whom I have admitted for surgery. They were looking all fit. Yeah. They were young patients. And their sample was sent for the RT-PCR, and the surgery was planned next day morning. And they became positive. Means 9 or 10 patients, I remember, they were positive just before the surgery report came. So, okay. And 2 patients that RT-PCR was fine, but HRCT was showing almost a significant lesion, to whom we have postponed.
What about you, Guruvar?
I agree with Brajesh. In my setup also, couple of young patients came with a road traffic accident, somebody having fractured patella, somebody having fractured femur, and they were totally asymptomatic. Their X-ray chests were completely normal, and we were planning for surgery. Only thing, all these patients we keep in a different zone. We don't allow them to mix up with the entire hospital patients, and they turned out to be COVID positive. And then we had to postpone their surgery, shift them out. 99% of these patients, they went home. They did not go to any other hospital. They consulted a local physician, treated themselves, came back after 2 weeks with another COVID report, which was negative. And then we readmitted them and operated, and everything went uneventful. But, these asymptomatic carriers, I think, is something which we have to keep in mind, and we have to be very careful about them.
In the last 6 months, we have around 10 patients who became positive. And one patient, in fact, you remember month of May, the moment lockdown was lifted, we done a lot of surgeries. And that a lot of patients came. We thought that was the end of the story. And then again, from June, we have gone back to another sort of self-lockdown. So May, we operated a lot of patients. I operated one patient who is around 72, knee replacement done. We was waiting for a long time. He said, I want to get it done. Everything went on well. He was fine for June, July, August. And in September, 3 months after the surgery, he got positive. And COVID, the CORAD is 5, and severe lung infection. Got admitted in our hospital, ICU'd, intubated, and expired. I lost one patient.
No, but that's someone who's got reinfected outside. We just saying they came in and none whatsoever. That means. None whatsoever. What about you, Dr. Pal? Do you have any specific numbers?
Yes. Initially, once the lockdown is over, we just opened among one male and one female ward among the four wards. So initially we started admission of the semi-elective surgeries like that. But in our hospital, as the waiting period is much more, so one patient initially becomes negative, but once after 2 weeks, once he started become operated. So just before operation, before the day of operation, we just send the report and has become positive. So and another case, it was negative, absolutely negative, but just on the day of operation, the test was sent it and operation was done, and just after the operation it was came positive. So that after these 2 cases, we actually separate the ward that is on the isolated ward is created, isolation ward is created, and all the cases we again rechecked. Even the initial report was negative, still after the operation, after the admission, we check by the RT-PCR, and if it is negative, then only we operate within 48 hours. If still it waits for it, the gap between the RT-PCR and the operation time is 7 days, crosses 6 or 7 days, we repeat the RT-PCR. So without this, we didn't do the operation.
Brajesh, how did you tackle this patient who said that he has got a gift from your hospital?
So basically, he was an outstation patient. He was almost 150 kilometers from my place, Jabalpur. So he got admitted in one of my friend's hospital, and he was almost asymptomatic. Basically, just he got some cold and cough, and he got tested. So report was positive, but when he got tested again after 5 days only, then his report was negative, and he was almost asymptomatic for 3 to 4 weeks. So 3 weeks means. So nothing else, nothing significant.
Because sometimes it becomes a bit difficult. Now at least things have died down, but I think those who had such experiences during the months of maybe May and June, I think that time the public sentiment was quite different.
Exactly.
You know, if there was
We lost Sachin.
Yeah.
Yes,
Yeah.
I guess
it's unstable.
in fact,
So sorry. I think just a bit of unstable internet now. Again, it's unstable. Okay, good. So I think there's one more question that has popped up. I'm going to ask Dr. Kakatkar to answer this question. And the question that has come up is that what is your take on post-COVID reactive arthritis? Because a lot of these patients are coming in now with post-COVID reactive arthritis. So if Dr. Kakatkar, you could give your current recommended treatment, we'll also ask Dr. Pal what is his institute sort of treating them in what different way.
Well, I think it's like any other reactive arthritis, and it was like we used to see in different kinds of viral infections in the past, or even some of the bacterial infections involving GI tract. We have seen some post this kind of a reactive arthropathy, and I think one of the best drugs for this reactive arthropathy is indomethacin, and we have been using, unless there is an intolerance to the drug. That's one drug which gives good results. And in some of them who came with very severe joints, we had to use.
I think we've lost it probably. Yeah.
In my institution, yes, it is the number of this sort of patients is increasing. There is a multiple pain in different parts of the body following a fever. There may not stamp it as a COVID infection, but there is complaining of the severe running nose, fever, different types of pain in different parts of the body, following which the pain in multiple parts of the body persisted, and even there is the sleeplessness, there are different disturbance of the sleep is complaining of, and every parameters of inflammatory arthropathy is negative. So if we examine, there are some hypovitaminosis D is present in most of the cases. So what we have actually treat this, that is a multimodal approach. Initially, if there is a severe painful joints, we use the orthosis just for the local rest. And once the pain has subsided, we started the mobilization and the rehabilitation, along with some inserts. Among the inserts which we start actually either naproxen or that is etoricoxib, naproxen and etoricoxib. And if still the pain persists, then we can add some another inserts for the local for the temporary period. But etoricoxib, the benefit of etoricoxib is you can continue for at least 2 to 3 weeks consecutively. After that, and alternate days for another 2 to 3 weeks. That is very, and this sort of prolonged period is required for these patients, along with some treatment of the hypovitaminosis D, some physiotherapeutic measures, local anti-inflammatory measures like that. And along with that, some patients, even after that, it requires some disturbance of sleep and mood problems and all those things. For this, we actually add some pregabalin and nortriptyline, and along with some with or without methylcobalamin. But the problem of this drug is also very useful for this relieving symptomatic relief. But the problems of these drugs is excessive sedation and some vomiting these things. So that is why what dose I follow. Actually, we start very small dose for 10 to 12 days. After that, we actually start the actual dose. There is half tablet for at the 7 p.m. with some foods for 10 days, followed by half tablet with lunch, followed by and half tablet in the evening for 3 to 4 weeks, followed by again half tablet. So gradual increasing and gradual tapering. So I think this is the modes of treatment we actually follow these cases.
Yeah, perfect. Thank you so much. Dr. Kakatkar, I think we just lost you, sir, for that moment. You were saying that indomethacin is your drug of choice. Would you like to just,
Yeah, I think for these reactive arthropathies, even the rheumatologists, they recommend use of indomethacin as the first drug of choice. And those patients who can tolerate it, I think it is the drug which gives excellent results. And those patients who do not tolerate that, then we have to go for drugs like etrocoxib or etrodolac, which are comparatively better tolerated by the GI tract. And that probably takes care. In addition to that, sometimes, you have to give steroids. The choice of steroid normally I use is usually deflazacort, and we give it in tapering doses for about 8 to 10 days. And usually the patients settle down.
Okay, perfect. All right, wonderful. So I think, we're past 9:30. We said that we should close at 9:30. So if any of the attendees would have any questions, we'd be more happy to take them. And I think the long and short of today's lovely panel discussion has been that we are all more confident now. We are more sure of the way we approach our practice clinically. It's very heartening to see that across all boards, whether it be a large government medical center set up or a super specialty hospital in central India, or wherever it is. And we are definitely bouncing back. These are good times. Everything is coming back. We've been lucky that we got some time to hit the restart button. We could reset ourselves. We are looking and coming. Guruva's comments were very apt, where you need to do nothing different. But I think it's basically how you instill the confidence. All of us are taking extreme precautions, and we should continue to do the same. Brajesh came up with some very good comments, where he did discuss various ways as to how to handle these situations, how to move ahead, how we conduct outpatients. Dr. Pal gave us useful insights, where he told us about the way he has layered up his hospital practice, how he's filtering the patients in, how he's ensuring that his staff are well protected in addition to his patients, which is very, very important. Dr. Kakatkar sir gave us very useful tips as to how to conduct an outpatient, how to manage the main problem of osteoarthritic patients, treat them cautiously, talk to them, instill confidence in them, very generously use nutraceuticals like undenatured collagen 2, as well as bioactive collagen peptides, which help in alleviating symptoms. And once I think they deserve the surgery, then of course we do it taking all the precautions. So I think with this very fruitful last 60 minutes, I've had a lot to learn. I've had a lot of useful points to take back home, where I could sort of decide as to it gives me more confidence for me to move ahead and advise the correct treatment for my own patients. And I think this has definitely left me a lot more enlightened in the last 60 minutes. So I would take this opportunity to thank Dr. Vijay Kakatkar sir, Professor A.K. Pal, Dr. Guruva Reddy, my dear friend, and Dr. Brajesh from Jabalpur for sharing and spending their valuable time with us on a Wednesday evening. And I would also like to thank Sanofi for this fantastic initiative in which they have helped enrich our lives, both for us treating surgeons as well as all our patients through their various innovative techniques and modalities. And I hand it over to Dr. Rakesh to give his closing comments. And Dr. Rakesh, over to you. Thank you again from behalf of all of us. And if you have any questions that have come to you, please, please feel free to ask them right now to the panelists. Otherwise, it's your stage for any closing comments.
Yes, sir. Thank you so much, sir. I cannot agree more than what you have said. These last 60 minutes have enriched us more. And as I said at the start of the session, after hours of discussion, we may not come to know who will come, Biden or Trump, but we have definitely in these last 60 minutes have learned important clinical pearls from our experienced experts on how to manage our patients in these current times. That's an excellent discussion, very insightful, very enriching. Thank you so much, everyone. I would like to thank all the attendees also who have joined. Yes,
Dr. Rakesh, I'm just going to interrupt you. There's one very quick question which has come up, which I want to very quickly put across to Dr. Guruva and Dr. Pal as well. The question that has come up is that in COVID times, do you add extra antibiotics or dual antibiotics in your bone cement?
Nothing.
I think from me, the answer is no.
Nothing.
Anybody else has got any different views?
Yeah,
so
no.
So there is no relationship with increased risk of periprosthetic joint infections in this COVID times. So I think just go on and do your own practice. Sorry, Dr. Rakesh, to interrupt, but I felt this was a very good question. and this need to be cleared off before we move ahead.
No issue, sir. Thank you so much, sir. That was excellent session and you have moderated it amazingly. Thank you so